Hello, I'm Deepak Bhatt from Brigham and Women's Hospital and Harvard Medical School. I'm here at a really exciting European Society of Cardiology in Paris, and I'm going to recap for you some of the trials that I thought were particularly interesting. Actually, these are all trials presented on the first day of the late-breaking clinical trial session. The first trial, or two trials, are THEMIS and THEMIS-PCI. I was fortunate to co-chair those studies with Professor Gabriel Stagg. And THEMIS is actually the largest trial of diabetes done to date, studied ticagrelor versus placebo on top of aspirin in stable patients with diabetes, found an overall 10% relative risk reduction in cardiovascular death, MI, stroke. THEMIS-PCI was the 58% of patients in THEMIS who had a history of PCI, on average 3.3 years prior to randomization. And what we found there was a 15% relative risk reduction. Now, there was an increase in bleeding in the overall trial, in THEMIS-PCI as well, but in THEMIS-PCI, the bleeding excess was a little bit less than in the overall trial. And importantly, in the overall trial, small signal, statistically significant finding, but an increase in intracranial bleeding from 0.5 to 0.7%, largely traumatic subdural hematomas associated with falls. But in the PCI cohort, probably because they'd been exposed to DAP before and not had problems, there was no excess in intracranial bleeding. The rates were rather similar. So what we concluded is, in terms of net clinical benefit, the patients from THEMIS-PCI, that is diabetes, stable coronary artery disease, remote stenting, that those sorts of patients, if they're at low bleeding risk, might be considered for ticagrelor in addition to aspirin. So that's THEMIS and THEMIS-PCI. There were another two heart failure trials presented, both of which were really interesting. DAPA heart failure that looked at dapagliflozin versus placebo in patients with heart failure with reduced ejection fraction, with or without diabetes. The really novel part was the without diabetes. And the overall trial was positive, significant reductions in the primary endpoint, also significant reductions in cardiovascular death, significant reductions in hospitalization for heart failure. So the overall trial was really quite positive, with consistent findings in the patients with and also without diabetes. And it's that latter point that really made this trial very exciting. The heart failure with reduced ejection fraction diabetes patients, that's important. We had subgroup data from other trials that suggested that diabetic patients with HFrEF would particularly benefit from SGLT2 inhibition, but this is the first dedicated trial to prove it. And the non-diabetic patients is just really groundbreaking to see that in HFrEF patients without diabetes, that a diabetes drug, or maybe I should call it a heart failure drug now, an SGLT2 inhibitor, dapagliflozin, could reduce their rate of important events like the composites of death and hospitalization for heart failure. So overall, a really positive, practice-changing trial. The other heart failure trial that I thought was really well done and important was the PARAGON trial, looking at sacubitril valsartan versus valsartan alone. That trial, as the press release had said, narrowly missed its primary endpoint. We found out here what that meant. P-value essentially of 0.06, so it really did narrowly miss it. And I thought there were some subgroup findings here that are believable and potentially actionable. So while the overall trial wasn't statistically significant, it looked like the patients, and these are HF patients, heart failure with preserved ejection fraction. We already knew from Paradigm that HFrEF looked really good for sacubitril valsartan. But here with HFpEF, there was benefit in those patients with lowish ejection fractions. HFpEF, of course, is a range of ejection fractions, but here in the lower range of what they called heart failure with preserved ejection fraction, looked like the drug was working. So I think the key is, if the ejection fraction is reduced by a lot, we learned in Paradigm, or by a little, we learned in Paragon, those are the patients that seem to benefit from sacubitril valsartan. There was also a finding in a subgroup of women that there was benefit in Paragon. I'm not 100% sure how to put that together. That, I think, is interesting and deserves future study, but would be in need of confirmation before being actionable, in my opinion. I'm sure that'll be a point of debate. The final study from that session I'm going to mention is the COMPLETE trial. I was lucky to be on the data safety monitoring board of that trial and got to see it in evolution. And just a fantastic trial, a much needed trial, looking at patients with STEMI undergoing primary PCI, randomized to either receiving culprit-only revascularization or complete revascularization. And what was found was a resounding win for complete revascularization. a significant reduction in the composite of death, the recurrent MI, largely driven by recurrent MI, but nonetheless a large, significant reduction. So a home run. And while many U.S. physicians were probably doing complete revascularizations anyway, this actually provides data to support that practice. There were some smaller trials that supported it, meta-analyses that supported it, but this trial nailed it down, I think, definitively. Now, what about the timing of that complete revasc? Do you have to do it Saturday night? The answer, thankfully, is no. So to the interventionalists that are watching, you still have to come in at night, do the primary PCI, but at least you don't have to complete the revascularization then. You can if you want to, but you can wait till the next day or a week later or sometime down the road over the next week or two. Because they looked at the data, those that had it during their index hospitalization, after discharge in the few weeks that follow, and both subgroups seem to benefit similarly. So this is also an important finding and an important message. You don't have to do the complete revasc in that patient whose creatinine is 2, or you're sleepy, or they're sleepy, or somebody is sleepy and you don't want to do it at 2 in the morning. Fortunately, it's okay to wait to complete the revasc. You have to do the culprit, but you can wait to complete the revasc till the next day or even after discharge. So this is interesting scientifically as well, because it shows that the benefit was largely in later MIs, not just MIs in the next month or 2 after randomization, but a long-term effect. I would also say, maybe this is going too far for some people, but I also say this supports the concept of complete revascularization. It also provides some impetus for revascularizing tight lesions even when they're not associated with an MI per se. Of course, all these patients had an MI, but those non-culprit lesions weren't causing the MI. So we'll see what the ischemia trial shows, but nonetheless, it provides some rationale for treating stable lesions in patients that have shown instability and plaque rupture by having a STEMI. But we'll see what you all think about that controversial point. At any rate, a fantastic ESC. There were a lot of other great trials too, but that opening session carried a lot of punch.